Welcome everybody to the Expert Talks. This is a brand new section on our channel that we are bringing in and incorporating to bring experts in the field, whether it's medicine, whether it is law or all other fields. On today's episode, we thought it's worthy to have an expert in the field of breast cancer and breast cancer awareness. The topics that we want to discuss today is early detection and treatment, and what options are available out there for the women. It's a very technical, very difficult subject, but so necessary. Please don't worry about writing any of the information down. We will provide everybody with a PDF that is downloadable and free at the end of the show at the bottom, as well as a link where you can go and check out the expert's website and perhaps make an appointment. Next to us, as always, Anna-Marie Meyer and the doctor himself, Mr. Eugene Jooste. Welcome to our show, sir.
Thank you.
Every time it comes to your health, it's always an emotional topic, but it's so necessary. I mean, we're having an off-camera discussion, and you said, you recently went for a checkup, and the preparation, the rumors, the stigma. Is it going to be a painful experience? I think, can we dive into that and take it away from there? I've spoken enough. The expert's there now.
Thank you. We realize that a lot of information is out there, and the negative information regarding the diagnosis of breast cancer, on the one hand, relates mostly to the discomfort or the pain that the patient might be expecting to feel, or that a friend of hers had felt, or a friend of a friend of a friend had felt, and which then prevents too many people not to come for the mammogram. Mammogram is our basic first line of investigation in the 40-plus year category for breast cancer. We do also use ultrasound as a study. Prior to 40, we could do ultrasound studies to ascertain concerns regarding what patients or doctors had felt. But the mammogram is our gold standard that we use. It's a relatively painless, mostly painless procedure where it's very brief, and the information that we have is our roadmap, what's in the breast. So the roadmap gets us to ascertaining interesting areas that needs to be further evaluated. Of course, lots of findings in the breast can be normal. It doesn't have to all be cancer. So when we look at the mammogram as radiologists, we interpret the findings and decide which areas needs extra attention.
So on that point, if there's a lump or something is felt, a person immediately goes worst of the worst. And on your point now, it's potentially something that's normal.
Yeah, there'll be more non-cancerous findings in the breast than cancerous findings.
Got it.
So we understand that it's the most prevalent cancer at the moment under females. Remember that men can also get breast cancer, but they've got a 1 to 100 ratio more or less for every cancer we diagnosed. And men must also be aware of the fact that they can develop cancer.
I was not aware of that.
I think that's an important fact. If we diagnose 300 patients in a year, we would probably find about 3 men in our database. So the stats are quite accurate for that. And men, as we understand it, can have benign conditions like gynecomastia, which develops in men regarding impairment of liver function and imbalance of hormones, depending on their health. And of course, an interesting fact about gynecomastia is that the youngsters also start developing that with a love of gym work and becoming big and strong. They often take supplements that are either tainted or develop gynecomastia in these guys. And of course, our favorite pastime lately, that can probably be a topic one day, maybe you've had it already, is the cannabis trade, which also increases the breast tissue in youngsters.
Oh, wow.
And that is misleading because the guys don't look so cool anymore, and they eventually get uncomfortable with it happened, and they don't know why it's happening. So they would come to us and we do a diagnosis. We'll find the problem, and we'll, with a bit of chatting, a bit of a conversation, discover that, yeah, they've done it.
Yeah.
And based on that, it can be return to normal once the stimulus is taken out. And it's not everybody who gets that. So it's not as if your first joint will get you big boobs.
Got it.
That's not the problem with that. So that's another topic.
Yeah.
I mean, it's contentious, and I think it can come up, and there are also many aspects that we could branch into eventually. But coming back to breast cancer, if I may, I think once we've seen something, the ultrasound is our next tool, because I use the analogy, seeing as we've already spoken about Google earlier today. Google Maps we're all familiar with. That's how I arrived here. Thank you. And Google Maps brought me here, but the street view is our next level. That's ultrasound. So if you bring your street view mannequin in and you drop it on the map,
Love the analogy.
now you can see what
Closer
it looks
look.
like, what are the buildings like, what's happening there. And that's what you do with ultrasound. And once ultrasound reveals the information, we could then target a suspicious abnormality. We can never be for sure that it is abnormal or cancerous. We can see it's abnormal, we don't know why it's there, and we'll do a biopsy. And once we get the biopsy done, which we do right there in the rooms under local anesthetic, having discussed the findings and the different complications, they are minor, with the patients, we can do a diagnosis. I think that's the mainstay of mammography, is you cannot just do a mammogram and say, I think there's something wrong, see you in 6 months' time,
No.
or see you in a year's time. People want answers.
Yes.
And we, as radiologists, have the responsibility to provide that answer. And the answer is not just to the patient, the answer actually goes to the doctor, who's going to get involved. And we can discuss the different pathways of treatment. If
Yes, please, of course.
We go into this.
So just to summarize up to this point, make an appointment, go in. As you mentioned, you can do a Google Maps. So that will be the initial test. I just want to get the name right, which is mammogram. And thereafter, with ultrasound, we can do the street, the street view, and have a closer look. All that gets done on the first appointment.
First appointment, all based on what we find at the time. First, there will be a history. The patient will either just want to know what's going on as a routine screening,
Yes.
or she had found something, or she had not found something, had seen a gynecologist or a GP or a surgeon who's asked us to further investigate this. So when we call it routine screening mammograms, where it's completely asymptomatic, the patient is just coming because she knows she's making a difference to her,
Yes.
to her health.
And that normally is the routine screening after the age of 40.
That is correct, yeah.
What is the frequency of that screening that you suggest?
There are two groups of people basically with breast cancer. Normal folks, if I can use the word normal, and then those with a family history and an elevated risk for breast cancer.
Got it.
So we'll pay more attention to the ones with a direct family member or even genetic tests that have proven positive with a higher risk in breast cancer, to ask them to come every year. After 40, they can come for the
Once a year.
every year.
Got it.
And the routine patient without the family history and without the higher risk that we identified through the histories, they can come every we say 1 to 2 yearly follow-up. So
Okay.
sometimes at a year, maybe 18 months sometimes.
18 to 24
not more
months.
than 2 years apart.
Got it.
That's
Okay.
our principle.
So let's say, for example, God forbid there's something. What are the next steps? I think the great thing is that you'll know the same day. So there's no. I think a lot of people are afraid. I would be afraid to go and test and then, wait 6 months. What's the next? I don't know. That uncertainty will eat me.
Yeah.
And will they do a biopsy in every sense? So can you actually see, but this is just a normal gland and there's something wrong?
Yeah, there are certain characteristics of the findings that we could categorize and say that this is just fluid. It's a cyst.
Got it.
Lump is fine. We can just aspirate the fluid. Similar procedure under local anesthetic, and the lump is gone.
It's done.
Immediate peace of mind. Patient relaxes. We inform them that cysts can return and they can have another lump, and don't sit on another lump. Bring it to us and let's confirm that it's there. Because it could be a different lump.
Yes, sir.
And there are benign masses, non-cancerous masses that can develop in the breast, mostly in the youngsters between, say, 16, even earlier, but 16 to 30. We'll find that. And that's why we also, that we're not doing the mammograms too soon.
Okay.
We can talk about that now.
That's my exact question. They're not going to do a mammogram at the age of 16, but that self-investigation that you need to do, how often do you need to do it? Because I think there's a lot of people that's got a misunderstanding and then suddenly they feel something and it's not really. How obvious is that lump in your breast?
I think everybody is correct in saying that it's very difficult to do it correctly and to know what you see. I do examine every patient that comes to me, and even I cannot differentiate all the cancers from the cysts from that. We use our ultrasound, and that's our answer. We can immediately see that this is a different risk lesion. So the self-examination that should be done once a month after the period, after the menstrual period, because that's when the breasts are most relaxed, least stimulated. Do that. Don't do it every day because your breast changes every day. So do it in that week period before ovulation, after menstruation. That's when the hormonal levels are least active in your body, and you would be less confused if you do it that way. We also find that once we've cleared the breasts and said the lumps that you feel are fine, they can build up, I call it a database in their minds as to what their breasts are like. And they'll find something new. If they've got their rhythm and their routine and they confidently do what we help them to get, you find that a new lump can be detected, and this is different now, or this is like this or like that. And with that information, we get them into the self-breast examination routine, because many people say, "Doctor, I don't touch my breasts. I don't know what I'm feeling. I don't like that." A great deal of patients are actually, mostly the not touching would be because I'm afraid there's something wrong. I don't want to feel something because then I'm going to worry about it. So they often just book their examinations and come to us to give them the answers.
That makes sense.
Yeah. So that's why it's important. The medical aids they have benefits already allocated to screening mammography. They already know that it's a good tool to diagnose early cancer, because that's our mainstay. You've got to catch the cancer early.
Okay.
Becomes a lump more than 2 or 3 centimeters, or it goes through the skin, or it goes to the glands, you've lost that edge. You can still treat it, you can still cure, or move the negative consequences of the diagnosis away from the patient's outcome. But you end up with a more complicated treatment.
So the key is early detection.
Early detection. That's what we look.
And if it's detected, we've done the sample and it is cancerous, what are the options for the patient? Where do we go from here?
There's unfortunately a 3 to 4 day wait once we've done the biopsy. I know we want to get the answers quickly, but the pathologists need to look at this. So the samples that we provide will get through to the pathologists. We use different labs. We have a direct link to those labs and the pathologists, and they can give us the feedback. Because not all cancers are the same either. You get a slow-growing cancer, or you get a very aggressive cancer.
Got it.
That is graded on the histology. And then also the other characteristics of the specific cancer, whether there are estrogen and progesterone receptors, which would help us with a follow-up treatment. Certain characteristics of the cancer. And some cancers would have a very low grade for spreading. So if we see that, we're happy to see a certain look, and we're happy to diagnose it. Relatively simple surgery, followed by radiotherapy, and that's it. They move on. We see them next year, the year after that, and they're fine.
Got it.
We will, of course, always look at the other breast as well, because some cancers have a propensity to want to but also grow in the other breast. So I think your question about diagnosis, pathologist, we get hold of the results. We discuss the treatment options in our clinics. We have a combined clinic of experts who sit down. We have the oncologists, the surgeons, the plastic surgeons, the radiotherapists. Everybody's involved in that team. Every Tuesday we meet and we discuss all our cancers that we've had. And with the information provided by the expert panel, we get back to the patient and her managing doctor to decide, okay, this is a cancer that goes to surgery, or this is a cancer that first needs additional investigations, because some cancers now, if it has a propensity to spread, needs a CAT scan or needs further imaging from a radiology point of view. Once the oncologist knows that no glands, no liver, no lung involvement, then they can plan their treatment and decide, well, there's no need for chemotherapy in this case. Let the surgeon and the radiotherapist treat the patient and follow up, and we're done for that. They will always come back to us. Every year they'll come back because we need to monitor the possibility of regrowth. We can never predict that, but some cancers, funnily enough, has like a 10-year. Once they get to 10 years and we do our follow-ups, we suddenly see something that has come up, and we have to then test that again, pathologist, panel, and we go through the whole process of making sure that the best treatment options available can be offered to the patient.
Beautiful. I love the fact that there's a panel because there's opposing opinion. It's not a one-dimensional prognosis or one-dimensional treatment option. If you combine 5 or 6 specialists, they will each have a different point of view, and somewhere along the line in the middle will decide, okay, based on everybody's opinion, this is the way forward. I love that.
As a cancer patient, you know you've got a second and a third and a fourth opinion already.
Correct, yeah.
And you get the best outcome through that.
Yes.
And then obviously the worst is spreading. But then secondly is the mastectomy, the double mastectomy. And I know for women do not have breasts, I think is one of the worst things that can ever happen to you. And I know a lot is fine with it and they live through it. And there's people saying we've got a family history, so I will do the double mastectomy at a certain age. But I can just imagine, what is the support groups like for people?
I think when you are confronted with that decision, you're not alone. There are many people who we can assist you to help to get to that point. And very few patients end up with a double mastectomy for non-cancerous findings. There are groups of people who are anxious enough and worried enough about this that they opt for that decision. And we respect that. That's obviously the way. It's usually when we find that the breasts are actually what I would call very difficult to evaluate. Some breasts are very dense and very nodular, and we've got to really look. It's a very built-up area. If I'm on street view, as I say.
Yes.
And you won't miss anything, but you need to pay close attention and follow up regularly like that. But if we get to the mastectomy options, we will also consult with the doctors regarding risk. We will consult with the plastic surgeons because plastic surgery has an amazing range of ability to restore a breast, or at least the shape and the form and the because one of our challenges is when a patient had a mastectomy and she still has a relatively large remaining breast. So that creates problems for her in getting dressed and choosing clothes and balancing herself. So much so that they sometimes say, I should have done both at the time when I could. But it's such an individual choice.
Oh, how yeah.
And I also find that once people who might say, no, I would never want a mastectomy, I will not lose my breasts, I'm so attached to them, so to speak, that you would rather not know, number one, what is wrong, but secondly, no surgery. Don't operate on me, you must give me medicine, give me tablets. My friend had tablets and you can give me tablets.
Yeah.
And we work through those concerns and we get them to a point where they can realize that this is life-saving, these are the options. And what often happens is that we can give chemotherapy at a diagnosis before the surgery. So the surgery can be less aggressive.
Okay.
You've shrunk the cancer, we followed up, we've seen it's basically gone now. We can't leave it there because the risk of recurrence is too high.
Yeah.
You could maybe do a lumpectomy with radiotherapy instead of addressing the fear that she has. But it's so individualized and it takes such a lot of work with your team to get to that point and to understand that.
But it's a breast, unfortunately, is a female thing. That is the part that gives us that feminine edge.
Absolutely.
And I can imagine how difficult it is. I always used to say, I will do it, but now I'm not sure if I will. Because that is just the edge that we've got. That is that part of you. My next question is, we spoke about painful, the discomfort. Is it maybe because the breast is more dense and certain that the dense kind of breast is more sensitive?
That's true. That is our concern or our dilemma in that many people feel that painful breasts, there's something wrong. They feel there's something, let's cut it out, let's fix it, I've got very sore breasts. And we find that that's mostly hormonal, it's not a cancerous symptom. Painful breasts can get cancer, but pain is not a cancer symptom at the early stages of cancer. So we address the hormonal issues and the influences on the breasts. We look if she has a propensity to actually have cysts, which is part of the hormonal influence, little fluid bubbles that develop in the ducts. And that gives them a lot of peace of mind if we can say that this pain is actually hormonal. We can see there's nothing wrong. use these supplements and add this, or realize that you drink too much coffee, for instance. Coffee can worsen breast pain. It's not the trigger, but if you have 5 or 6 or I don't know, let's say more than 5 cups of coffee a day, or caffeine containing products, it's going to make it worse. So
I did not know that.
then they say, okay, well, I'm going to drink my coffee. I'll take the pain. Because not everybody wants to leave that. But they understand the physiology of the breast better. And we'll monitor that, and we'll give them the peace of mind to know that. Once we get to know them well enough, we can see a change in the breast that requires a test, or say, let's just make sure. So it's the regular follow-up. That's critical, I think, for us as radiologists to make a difference.
Well, the one thing I can assure our viewers of, I've gone for it not too long ago. And I postponed it for a couple of years due to the fact that everyone told me it's so extremely sore and you're going to have pain for the next 3 days. I did it. It wasn't that bad at all. So please never postpone. We need it.
Yeah. Thank you. Because that's what the women need to hear. Because it's easy for me to say it's not painful.
You haven't had the living experience, yes.
No. So based on that, we realize that we need the support of the rest of your friends. You must now share that information. We are going to share it. Because the bad stories, you know how it works. A little negative story goes to how many people.
Yeah.
And a good story, you keep it for yourself.
No, it's quick. It was a fast, convenient. I walked in, they gave me this little pink dress and a pink top. And I just laughed at myself. So it broke the ice a bit. But it was a matter of 15 minutes in and out. But they really take care of you. And it wasn't that painful. Maybe I expected worse, but the way they handle you, it's really not that bad. And that's why the only concern that I've got is maybe a denser breast might be more prone to a bit of a discomfort. That's maybe the only thing, but it's not sore for a couple of days thereafter. It's something, I'm glad I did it, because the moment I walked into that reception, immediately my emotions started playing around with me. And I am not an emotional person. I'm not sick. I never get sick. And then suddenly as you walk in, you start wondering, okay, maybe I postponed it for too long, maybe. And don't let this happen to you. Do it the moment you turn 40, and especially as you mentioned, if there's a family history.
Absolutely. And important with that point is, people think they don't have a family history, so they won't get cancer. It doesn't work like that.
Doesn't work like that, yeah, unfortunately.
So you still have a risk for breast cancer. It's still a 8 out of 100. There's still stats favoring your chances to get breast cancer. So it shouldn't be a reason to stay away to say, but nobody has cancer.
Is hormonal changes one of the biggest trigger in cancer, especially breast cancer, or not?
No, it creates the concern about lumpiness and pain and like that, but it's not triggering the cancer. Lifestyle, as in any body, will affect it, whether it's if you're unfit or you're overweight or you have consumed too much alcohol and you smoke and like that. All of those factors, environmental factors, will be increasing your risk. Plus that genetic change that is triggered in your body and suddenly the cell becomes cancerous. That's just life.
Good.
So I think my key takeaway, the number one key takeaway from this episode is early detection and constantly going for the checkups and making sure that you're healthy. And if there's something that gets picked up, early detection means a easier treatment or less invasive treatment. I hope you guys have enjoyed this informative chat with us. If you have, please, or if you have some questions that were perhaps not answered, leave us a comment. And remember, as we said in the beginning of the episode, we will be providing downloadable PDFs with the top FAQs, the frequently asked questions, as well as a link where you can go and make an appointment and just make sure that everything's fine, or perhaps have a early detection so that the process of the cure is nice and quick. Thank you very much. Hope you guys enjoyed it as much as we did. Take care and have a beautiful day. All the best. Bye-bye.